Hello and welcome everyone to our latest presentation. This is on TRALI, the latest update. Last time we explained the two-hit theory. Today we will go with the latest updates where we go much deeper into the pathophysiology of TRALI. Blood transfusion and adverse reactions are common as blood transfusion is a common life-saving treatment and it has many side effects. One of them is TRALI, that is transfusion-related acute lung injury. TRALI is rare but a very severe event. It can occur within 6 hours of blood transfusion. It is characterized by hypoxia, non-cardiogenic pulmonary edema resulting in respiratory distress. In 2019, new diagnostic criteria divided TRALI into type 1 and type 2 based on the presence or absence of ARDS risk factors. TRALI is a major cause of transfusion-related deaths in developed countries and is likely underdiagnosed in ICU patients. Mortality range from 5 to 25%, reaching up to 47% in intensive care and surgical patients. The first reported TRALI was in 1957. It was initially linked to the transfer of high-titer leukoagglutinins. It was formally identified in 1983 as a syndrome caused by transfused HLA antibodies. Antibody-dependent mechanisms involve both anti-HLA and anti-human neutrophil antigen antibodies, as estimated to be responsible for 50 to 80% of the TRALI cases. Current lab testing is inaccurate and may lead to underestimation of this test if you go for antibody detection as a diagnostic criteria. Now, there is also non-antibody mediated TRALI, which occurs in around 10 to 15% of TRALI cases, which is associated with biological response modifiers from stored blood components, suggesting a non-antibody mediated pathway. Despite significant advances in understanding TRALI, it is a complex pathogenesis and is not fully characterized, highlighting ongoing challenges in the area of clinical medicine. So coming to the pathophysiology. So first we will go to the two-hit theory. The first hit is the recipient's predisposition. This involves the activation of the pulmonary endothelial cells and the priming of the polymorphonuclear cells in the recipients. The next is a second hit, that is a blood component factor. This hit is triggered by mediators in the transfused stored blood, which activates these primed endothelial cells and polymorphonuclear cells, monocytes, macrophages, and platelets, releasing pathogenic factors. This leads to coagulopathy and intrapulmonary fluid infiltrations. This can be further divided into antibody dependent and independent. Now, there are three overlapping phases. The first phase is the priming step. In this phase, recipients relate the risk factors causing endothelial activation and the neutrophil priming through the endothelial PMN interaction. Next is a pulmonary reaction. This is the antibody or the biological response modifiers binding to the target cells and inducing a host response. Finally, you have the effector phase. This phase involves the damage to the pulmonary vascular endothelial barriers due to the nets and reactive oxygen species, resulting in a coagulopathy which will affect the lung pathophysiology. So these are the three basic steps: the priming, the pulmonary reaction, and the effector phase. We will go into the depth of each of these phases. So first, the priming step. Now in 1997, study using rat lung model showed that patients with TRALI had stronger PMN priming activity, especially those with underlying clinical conditions. Now, these conditions such as hematological malignancy, cardiac disease, hypertension, liver disease, chronic alcohol abuse, surgery, mechanical ventilation, trauma, and systemic inflammation are identified as first hits and risk factors of TRALI. Pulmonary disease and tobacco abuse also increase the TRALI risk. Now, patients with these underlying conditions in ICU are more susceptible to TRALI and notably have a higher mortality rate, that is 70% compared to typical 5 to 25%. Experiments involving the transfusion of major histocompatibility complex antibody to the mice showed TRALI induction influenced by factors like gut flora and pretreatment with lipopolysaccharides. Now, gut flora has emerged as a significant factor in TRALI priming, though its exact impact requires further research. Various studies have shown that low-dose lipopolysaccharide or C-reactive proteins can act as first hits in TRALI models. LPS activates cells via toll-like receptor pathways, while CRP promotes PMN sequestration in the lungs, activates the endothelial cells. The first hits facilitates the release of interleukins, macrophage inflammatory proteins, osteopontins, and an increase in adhesion molecules due to endothelial activation. This leads to PMNs being attracted to the lung and adhering to the ECs, creating a predisposition for TRALI. Conditions not related to the systemic inflammation like alcohol, hypertension can contribute to TRALI risk. This might involve mechanisms like nitric oxide production, enhancing the PMN adhesion. So here you can see these are the various risk factors that you can have for TRALI. The first hits like cardiac condition, liver, gut flora, trauma, systemic inflammation, intrinsic lung disorders, and surgeries. And this is a more magnified view how the priming is occurring inside the lungs. The next is a pulmonary reaction. Donors-derived risk factors include pathogenic antibodies, biological response modifiers, target hematopoietic and non-hematopoietic cells, which influence the TRALI progression. In mouse models, monocytes or macrophages are essential for pulmonary edema development, while neutrophils and platelets are less critical. Regulatory T cells and dendritic cells help ameliorate lung injury. ECs regulate PMN transmigration and has pivotal targets for TRALI induction. Now, PMNs are the main cells mediating lung injury in TRALI. Anti-HLA antibodies, particularly anti-HLA1, frequently identified in TRALI, interact with the antibodies and the neutrophil, leading to lung injury. Various molecular pathways such as NF-kappa beta, CXCR1 signaling, TOR dependent axis, NLR activation involve the neutrophil activation during the TRALI. Factors like lysophosphatidylcholins, CD40 interaction play a role in the antibody independent TRALI. These factors can induce neutrophil mediated endothelial cell damage. Anti-leukocyte antibody likely target the ECs, with HLA expression in the cells being a significant factor. Interaction between these antibodies and ECs can lead to a complement activation and TRALI induction. The transfusion of aged platelets and RBCs can cause endothelial dysfunction, contributing to the TRALI. Mechanisms involve ceramide-mediated apoptosis, necroptosis of the pulmonary ECs. Next is the role of monocytes and macrophages. Anti-leukocyte antibody binding to the antigen on the neutrophil and ECs may lead to PMN activation and the lung injury. Now, the class 2 antibodies sensitize the peripheral blood mononuclear cells, producing inflammatory cytokines and chemokines through the monocytes. Now, monocytes play a critical role by activating, which leads to neutrophil amplification cascades and endothelial damage. Experiments have shown that monocyte-dependent TRALI induction with MIP2 expression, upregulation, and neutrophil recruitment. Now, macrophages characterized as M1 pro-inflammatory, M2 tissue repair and implicated in TRALI, with M1 playing a critical role in the lung injury. Next is the recipient platelets. Platelets, traditionally associated with thrombosis and hemostasis, play a vital role in the TRALI. The role is complex and somewhat conflicting, with some studies showing platelets as key drivers and others as telling them to be dispensable. Now, platelet receptors are implicated in TRALI. Depletion and inhibition of the platelets have shown varying results in TRALI development. Now, new insights suggest that receptors on human platelets may have significant effect on TRALI pathogenesis. Now, these receptors can be targeted for future research and treatment of TRALI. Now, lastly is the dendritic cells or the regulatory T cells or interleukin 10. The role of the recipient T cells is vital, and it can help in aggravating and ameliorating the lung injuries. Particularly to the interleukin 10 secretion, it has a protective effect against TRALI. Now, the mechanism of IL-10's protective effect is not yet fully understood and requires further research. Next, what we come into is the effector phase, how the lung reacts to the transfused blood. Now we will have the factors that are neutrophil extracellular traps, that is the nets. Nets produced by active immune cells contain histones and granule contents that can kill microorganisms and restrict pathogen spread. In TRALI, the nets are released, directly damaging the pulmonary endothelial cells and exacerbating the lung injury. The complement system assists in the net production by activating the neutrophils. Net formation in TRALI can occur independently of antibody and is seen in hemolysis of the stored bloods, leading to hemin-induced net release as well. Next, we have the ROS, that is the reactive oxygen species, which is activated in the inflammatory process, and the trapped neutrophils in the lung produce these reactive oxygen species, damaging the endothelial cells, and the activated macrophages or the monocytes generate these, causing further endothelial damage and TRALI onset. Now, mice lacking the ROS production were protected from the antibody-mediated TRALI, highlighting the importance of ROS in TRALI pathogenesis. Now, there is also an imbalance in the coagulation and fibrinolysis pathway. There is microthrombosis, coagulopathy resulting in damaged endothelial cells due to transfusion of the pathogenic antibodies, contributing to the lung dysfunction. Fibrin deposition in the lung, a common feature in ALI, and is also observed in TRALI as it activates the endothelial cells, promoting the release of pro-inflammatory mediators, and vascular permeability is altered. Impaired fibrinolysis and increased coagulation in the lung is characteristic of TRALI. Next is prevention strategies. How can we prevent? Antibody-mediated TRALI prevention is very important. Donor management, that is strategies like male-only donors, male-dominated plasma excluding all exposure donors, and antibody screening has significantly reduced antibody-dependent TRALI. Antibody screening, this is considered a potential risk in corona-19 convalescent plasma donors and SARS-CoV-2 vaccination volunteers. Now, next is the detergent treated pooled plasma. Now, this reduces the anti-leukocyte antibody levels and has markedly reduced TRALI incidence. Antibody independent TRALI prevention, this can be done by leukoreduction, filtering out the leukocytes, pathogen reduction technology, that is Mirasol and Intercept technology, which improve the blood component safety, and platelet additive solution, that is PAS, which replaces the traditional residual plasma with PAS in Buffy coat pooled platelets, which may decrease the incidence of TRALI. Next is supportive measurements. Currently, there are no specific treatments for TRALI. The focus is on the supportive management, that is oxygen and mechanical ventilation. Research is to find therapeutic targets in all the inflammatory and anti-inflammatory pathways that we have just shown. Additional research is going on to find more novel drugs for TRALI. Continuous monitoring and assessment of the existing prevention strategies is essential to reduce the TRALI incidence. Now, regarding the blood transfusion management. In the blood transfusion management, the objective is to optimize the patient's hematological capabilities, decrease the bleeding, and limit unnecessary transfusions. So PBMs are important to decrease the incidence of TRALI. So as we said, in supportive care, we give only oxygen, ventilation, avoid diuretics because they can be associated with hypotension. Clinical studies have shown that ascorbic acid can limit the ROS damage and improve survival in TRALI patients, though we need more research on this particular thing. And there are more preclinical trials which are coming, like that is gut flora. Depleting the gut flora in mice has shown to relieve TRALI. Effector molecules like NETs and ROS, strategies like DNAs and targeting the NETs, disulfiram to block the NET, targeting NOS, ROS has shown promise. Neutrophils, regulating neutrophil aging using inhibitors like PTP1 beta inhibitors, dasatinib have shown to prevent the PMN activation. Endothelial activation, targeting endothelial activation by immunosuppressive cytokines like IL-35. Macrophages, blocking the macrophage activity or promoting the M2 activity is also being targeted. Drugs to prevent the platelet activation are being used. Finally, IL-10's protective mechanism by giving it through infusions is also being developed to see how it recovers the lung injury. So in conclusion, although significant advances have been made in understanding the TRALI-specific treatment is still lacking, the three-step pathogenesis, that is priming, pulmonary reaction, and effector phase, helps in understanding TRALI and developing stage-specific management strategies. Progress in prevention and treatment strategies to exclude anti-leukocyte antibody and BRMs from the blood products have reduced TRALI incidence. Clinical studies show promise in preventing lung injury by targeted therapies. So the future direction is the use of ascorbic acid as of now, because it has shown some potential benefits, and the other targeted therapies as we have shown. Thank you for your patience. So this has been the latest update in the TRALI.